Diabetes Mellitus Type 2, Group 8, by Hasan Abbas, Osama Abdelwahed, Mohamed Ahjerat, Ahmed Al-Hashim, Narissa Persaud, and Kardo Rashid. Hello everyone. Have you ever asked yourself what are the leading causes of death worldwide? In the present-day world, chronic diseases account to the key cause of fatality as well as disability globally. Chronic disease definition. The term chronic disease are used to explain long-term health issues that usually advance and develop slowly over time. The Ministry of Health and Long-Term Care stated that chronic diseases are usually characterized by severe progression, rarely cured, and significantly impair the everyday physical and mental functions. The 10 leading causes of death in 2012 in the world. A few examples of common chronic diseases are diabetes, cardiovascular diseases, cancers, and chronic respiratory diseases. As per the survey and studies conducted by World Health Organization, nearly more than half of the people who die from chronic diseases are below the age of 70. Every year, 6 out of 10 people die worldwide are due to any of these chronic diseases. Diabetes Mellitus Type 2. All these statistics makes it extremely important to discuss about one of the most hazardous chronic diseases, diabetes mellitus 2. This condition, which is commonly referred to as hyperglycemia, which is the most common variant of diabetes. Moreover, type 2 diabetes is a metabolic disorder where the body naturally elevates the blood sugar glucose levels, much higher than the predicted normal value. In fact, this medical condition is characterized by a relative lack of insulin. In other words, pancreas does not produce enough insulin. Hence, it is imperative that a patient diagnosed with type 2 diabetes should proactively manage the condition to lead to a rewarding life. The medical complications associated with type 2 diabetes is very significant, as neglect of the same may lead to the development of secondary medical conditions can be fatal. Cardiovascular diseases are the most significant cause of premature death among patients with diabetes. People with diabetes are at a risk chance of 2 to 4 times when compared to individuals without a history of diabetes to die of heart diseases. The reported rates of death due to stroke is also high among diabetes patients. Today, we will discuss all the aspects of type 2 diabetes, with special attention to the complexity of the medical condition, characteristics, symptoms, and types, addressing the secondary and complexities associated with the disease, and effective rehabilitation strategies. Finally, the presentation would propose to spread the light to the modern approach toward effective management of type 2 diabetes. Overview. Epidemiology is the study and analysis of the patterns, causes, and effects of health and disease conditions in defined populations. It is the cornerstone of public health and shapes policy decisions and evidence-based practices by identifying risk factors for the disease and targets for the preventative health care. Diabetes type 2 is a condition that many Canadians are currently afflicted with at high incidence and prevalence rates. Type 2 diabetes typically shows up later in life, although the incidence in children is increasing. The source of the disease goes back to insulin. Insulin, a hormone produced by the pancreas, facilitates cells to convert dietary glucose into energy. Specifically, in those with type 2 diabetes, their bodies produce insulin but cannot use the hormone to its full capacity. Hence, why the condition is also referred to as insulin resistance. Last, the body initially reacts to the pancreas, increasing insulin production. Over time, the organ cannot keep up with the demand, causing a build of glucose in the bloodstream. As a result, the adverse symptoms associated with diabetes 2 manifest. At first, the pancreas makes more insulin in an attempt to get more glucose in the cells, but eventually it can't keep up, and the sugar builds up in your blood instead. Type 2 diabetes affects kids and teens as well as adults, mainly because of childhood obesity.
Risk factors. There are a number of risk factors characterized by type 2 diabetes. We will go through the most prevalent risk factors as determined by current research. First is weight. The more fatty tissue one has, the more resistant the cells in the body become to insulin. Next is fat distribution. If the body stores fat primarily in the abdomen, the risk of type 2 diabetes is greater than if the body stores fat elsewhere, such as the hips or thighs. Inactivity. It is proven that the less active you are, the greater your risk of type 2 diabetes. Family history. The risk of type 2 diabetes increases if a parent or sibling has had the disease. Those who have grandparents, parents, or even siblings increases the probability. Ethnicity. Canadian first and second generation immigrants of African American, Native, Asian, Hispanic and or Latino, or Pacific Islander American show a high occurrence of this chronic condition. Age. The risk of type 2 diabetes increases as you get older, especially after the age of 45. That is probably because people tend to exercise less, resulting in muscle loss and excess weight gain. Prediabetes. This is a condition in which your blood sugar level is higher than normal, but is not high enough to be classified as diabetes. If left untreated, prediabetes often progresses in type 2 diabetes mellitus. Gestational diabetes. If a woman develops gestational diabetes when pregnant, the risk of developing type 2 diabetes increases. Also, if a woman gives birth to a baby weighing more than 9 pounds, the baby is also at risk. Polycystic ovarian syndrome. Simply put, POS increases the risk of diabetes in women. It is a common condition characterized by irregular menstrual periods, excess hair growth, and obesity. Lastly is smoking, which stresses and lack of sufficient sleep and are also said to increase levels of risk. Here on this slide, we have a few causes of type 2 diabetes. The first is weight. The second is metabolic syndrome. This is when multiple conditions such as increased blood pressure, high glycemic and triglyceride levels, and obesity occurs in an individual. Next is excess glucose in the liver. After a meal when dietary glucose levels are high, the liver stops secreting glucose. In some, the liver doesn't have the biological signals to stop secreting glucose, leading to excess levels of the substance in the body, causing diabetes too. Next is intercellular communication. When the receptors and signals do not function as they should, affects the cells that make insulin and track glucose levels. This can lead to a chain reaction that causes diabetes type 2. Next is beta cells. If the beta cells don't work as they should, they make the wrong amount of insulin at the wrong time. And lastly are genes. There are specific genes that affect how the body makes insulin. In this slide, we have symptoms of type 2 diabetes. The first is increased thirst and urination. Excess sugar buildup in the bloodstream may result in leaving one thirsty, which leads to excessive drinking and urinating. Next is increased hunger. Without enough insulin to move sugar into the cells, muscles and organs become depleted of energy. This triggers intense hunger. We also have weight loss. Without the ability to metabolize glucose, the body uses alternative fuels such stored in muscles and fat. Calories are then lost and excess glucose is released in the urine. Fatigue. If the cells are deprived of sugar, you may become tired and irritable. Blurred vision. If your blood sugar is too high, fluids may be pulled from the lenses of your eye. This may affect your ability to focus. Slow healing sores and frequent infections. Type 2 diabetes affect the ability to heal and resist infections within the body. Areas of darkened skin. Some people experience patches of dark, velvety skin in the folds and creases of their bodies, usually in the armpits and neck. However, if you feel one or several of these symptoms, it is important to consult with a physician. There are also a number of complications that may arise due to diabetes mellitus 2. Heart and blood vessel disease. Diabetes dramatically increases the risk of various cardiovascular issues. This includes heart attacks, strokes, and narrowing of the arteries, which can increase blood pressure. Nerve damage. Excess sugar can injure the walls of the capillaries that nourish the nerves, especially the legs. This can cause tingling, numbness, burning, or pain that usually begins at the tips of the fingers or toes and gradually spreads upward. Eye damage. Diabetes can damage the blood vessels of the retina and potentially lead to blindness. Diabetes also increases the risk of other serious vision conditions such as cataracts and glaucoma. Foot damage. Nerve damage in the feet or poor blood flow to the feet increases the risk of various foot complications such as infections and cuts or blisters. These complications can often be seen together due to type 2 diabetes mellitus having several comorbidities in nature. For example, neuropathy, eye damage, and skin conditions can often be seen together in severe cases of this disease.
The complexity of diabetes mellitus 2. Multimorbidity is a condition in which a person has two or more chronic illnesses, whereas comorbidity is a medical condition that causes or is caused by another condition. Type 2 diabetes, by nature, has several comorbidities. It has been found that at least 90% of persons with diabetes have an excess of genetic environmental factors converging to produce an insulin resistance, abnormal triglyceride formation, and accelerated lipolysis, which contributes to dyslipidemia, oxidative stress, and atherosclerotic vascular diseases. Together, these comorbidities quadruple a person's risk of myocardial infarction and stroke. The Medical Expenditure Panel survey found that almost 9 in 10 persons with diabetes reported an additional chronic illness, and 1 in 7 reported 4 or more. The presence of 2 or more chronic conditions in an adult with diabetes significantly increases the risk that he or she will have a major depression, which negatively affects engagement in self-care.
In this slide, there are various definitions of chronic disease given by many different organizations. World Health Organization defined chronic disease as disease of long duration and generally slow progression, which is a vague sentence and can be considered a weak statement. However, McKenna and Collins propose multiple criteria to explain chronic diseases. But it's this definition by the Ministry of Health and Long-Term Care that is necessary to adopt, mainly because it was created for the population of Canada, but also because it is a comfortable medium between a too broad definition and a more restrictive definition. In 2011, Canada endorsed the United Nations Declaration on Preventing and Controlling Non-Communicable Diseases. The declaration acknowledges the 4 main non-communicable diseases as cancer, diabetes, chronic respiratory diseases, and cardiovascular diseases. More specific definition lists a number of criteria. The most significant common criteria is duration. Some definitions suggest they last a minimum of 6 months, but in general, they last for a prolonged period of time. Another characteristic is non-contagious and/or non-communicable. Because insulin resistant is not something that's transferable through airborne pathogens, nor is it contagious, it is, however, a developed condition due to an individual's lifestyle choices. Hence, it fulfills the sound criteria of it behind non-contagious and/or non-communicable. Impairment is another criteria the disease meets. Diabetes impairs daily normal functions of patients by causing thirst, polydipsia, lightheadedness, blurry vision, and strict diets preventing them to eat certain common foods. The last criteria diabetes type 2 fulfills is progression in severity. If not treated, diabetes can progress into neuropathy, amputation, microvascular disease, and increased glucose levels, which result in reduced blood circulation. Now we will begin to discuss the rehabilitation program for diabetes mellitus type 2. The Copenhagen Rehabilitation Program was developed to educate patients with chronic disease in maintaining or developing a healthy habit to stabilize their disease status. It also prepares patients for a healthier lifestyle to better suit their current condition. The Copenhagen project aims at rehabilitating a number of chronic diseases. Diabetes mellitus type 2 is among one of them. According to the illustration, the program aims to improve care for chronic disease patients, provides methods of prevention and awareness, and prepares patients for a healthier lifestyle. The program also addresses the main factors that lead to diabetes mellitus type 2, which are inactivity, consumption of unhealthy foods, inappropriate food portions, and genetic factors of each individual. The rehabilitation program has 2 types of interventions, the group-based and the individual-based. The program describes the 2 interventions, their content, their focus, and effectiveness. One of the aims of the program is to compare the metabolic, physiological, and psychological factors that each patient exhibits between the group-based and the individual-based interventions. The aim of the outcome is to have a better glycemic control for patients. First, let's talk about the group-based lifestyle intervention, which consists of 4 programs, with the last program being optional. The first program is the education program. This consists of 1 weekly group session of 90 minutes for 6 weeks. Among the groups, health professionals were assigned to provide education on pathophysiology of DM2, the environmental factors, inheritance, physical activity, blood glucose level, and other factors like smoking, which can play a role on the disease. The second program is the diet instruction program, which consists of 2 3-hour group-based cooking courses and 1 session in the supermarket to educate patients about food choices. This program aims to teach patients on healthier food choices and teach them how to select the right foods and methods to cooking it. The third program is the physical exercise program. Aerobic and resistant exercise occurred twice a week for 12 weeks at intervals of 90 minutes a day. Each training activity is custom designed by physiotherapists who choose the right exercise for each patient's level of fitness and need. The last program is the optional smoking cessation course. If needed, it is available for individuals. For the individual-based section, there are 3 sessions with the dietitian that is also experienced in motivational techniques. The dietitian sets up a schedule for the patient according to the biochemical and medical records of the patient. The goal is to have 2 30-minute follow-up visits for evaluations, plus an optional smoking cessation course if needed. The Copenhagen project aims at comparing the outcomes from both interventions. It measures the quality of self-rated life, the glycemic control, and weight loss. Those are compared from both interventions, and then the best is presented for data to be studied. The Copenhagen program also compares both methods used in the 2 interventions, the exercise and education lessons, to better understand the results of which is conclusive. Now we'll talk about the effectiveness of the Copenhagen program. A research publication written in the journal Diabetes Mellitus provides a 1-year follow-up of the Copenhagen Type 2 Diabetes Rehabilitation Project. The results indicated that there was no significant difference between the Copenhagen group-based rehabilitation project in comparison to an outside individual counseling for glycemic control and health-related quality of life in patients with type 2 diabetes. The program's downfall. These differences were expected to be dramatically different, seeing that more resources were invested into the Copenhagen group-based project by as much as twice the amount of the resources invested in the individual program. For example, the Copenhagen program had 57 hours of contact between a healthcare professional and the patient, whereas the individual group had only 6 hours of contact. On a high note, the program did show success at the 1-year follow-up visit in systolic and diastolic blood pressure. The Copenhagen program indicates a decreased level of blood pressure when being compared to a baseline value. The results show the decreased diastolic blood pressure by 4 mm hemoglobin and a decreased systolic blood pressure by 6 mm hemoglobin. According to epidemiologists, if these results are sustained in long-term effects can benefit individuals with type 2 diabetes by lowering risk of stroke by 40%, as well as lowering risk of ischemic heart disease by 30%. Additionally, results indicated an improvement in the level of fatigue and physical function patients felt prior to the initiation of the program. The article then further exemplifies areas of limitations that may occur during the process of the Copenhagen Rehabilitation Project. To begin, the project failed to blind patients and investigators about the purpose of the study, which opened the risk of biases. Investigators were told to examine patients after the completion of the intervention with full knowledge of the program that was in place. This allows an opportunity for prejudicial favor or opposition by the investigator that may have affected the results of the program. Another area of concern noted by the article are the high withdrawal rates in the program that can contribute to attrition biases. A large amount of withdrawals might contribute in a larger observed weight loss, especially when most dropouts in the program were more obese than the completers in the program. The purpose of the Copenhagen program was to compare different methods of interventions and measure how successful they were in achieving the overall goal. According to the results, Copenhagen group-based rehabilitation program demanded more resources and achieved no significant difference when being compared to individual counseling in outpatient clinic. The article stresses the limited value of short-term educational programs and highlights areas where research is needed to optimize interventions of type 2 diabetes to achieve sustainable health outcomes.
This concludes our presentation. Here are our references. Thank you for listening.